Okay, welcome to our live stream at Duke Spine. This patient is here for thoracic pain. He has pain in his facet joints, many of them, as a matter of fact. They're running from, up at C12-11-10-9, T9, all the way down to L2, where he has a fusion. And he injured his back while on the job. He has thoracic facet joint pain on both sides. We've done diagnostic medial branch block on him, and it worked. And he has classic facet pain, which is off midline, and it's located to the sides of the spine, about 2 finger breaths to the sides of the spine. Shot. And we know that he has facet pain because we numbed up those joints and it took his pain away. So now we're here to do what's called a rhizotomy, where I go in and basically deaden the medial branch of the dorsal ramus. The medial branch of the dorsal ramus is basically a nerve that travels to the facet joint and provides innervation, which is pain signal information from the facet joint to the brain. And normally your facet joints don't hurt, but when you injure them, they can hurt. And the reason they hurt is generally the same reason a disc will hurt when it's injured, is inflammation. So this patient has inflammation pain in his facet joints, in his thoracic spine. And we're here today to basically alleviate that pain with a procedure called a rhizotomy. And for those of you who have heard of rhizotomy, you may have heard of it as a radio frequency ablation in the past. That used to be how we did it, but the problem with radio frequency ablation is that the pain always comes back. So what we learned is that we could actually get rid of the pain permanently if we do a different type of procedure. And that different type of procedure requires more energy to be delivered to the joint, and it requires that we are able to wand or move the probe around in the area that the nerve would normally be. Okay, so basically, if you look at a radio frequency ablation procedure, conceptually it makes sense. You're supposed to go in and kill the pain nerve to the joint. The problem is that with that procedure, the nerve grows back. And when the nerve grows back, the pain comes back. And unfortunately, the nerve can grow back very quickly, like within a few weeks even. So at Duke Spine, we started to ask ourselves, well, what could we do to more permanently eliminate pain from the nerve? And the answer was to use more energy, but also to direct the energy in the area where the nerve would be. Shot. And so that's what we started doing at Duke Spine. And as a result of that, we've been able to successfully eliminate facet joint pain in patients with facet joint pain by doing this modified type of, it's not a radio frequency ablation, but it's called a rhizotomy, where you're killing the pain nerve, but it's done with higher energy and a wand. It's called the Duke plasma rhizotomy. Okay, move south then. Shot. Let's see where we are. Come on, Monica. Nice. So, you're fine. You're fine where you are. Don't move. So we've done already 4 facets above. We're going to do now L1, T12-L1 and L1-L2. So it's our last 2 that we're doing. Shot. Shot. So the first step in the procedure is to bring a needle down to the junction of the transverse process and the superior facet, which you can see on the X-ray shot. There it is, right there. See where the tip of the needle is? Monica, show them the tip of the needle. Show them tip of the needle. That's correct. And right exactly at that spot, that's where the nerve, the pain nerve, is supposed to be. So by targeting that spot right on the bone, I'm able to kill the pain nerve effectively, which is a good thing, believe it or not. The only other way to fix this, folks, is a fusion. And a fusion requires screws and rods, and we don't like fusions at all. Notice how I burn under the skin, Luis. You see that?
I see that. Yes, sir.
Shot. Shot. Getting close. So to get to the target, you must use X-ray. We call it X-ray navigation. Okay? So we use the X-ray to navigate, and what we're really using is his spine, the bones of his spine, the anatomy of his spine. Because those bones, we know them, we know their structure, we know where the nerve is supposed to be relative to the bones. So the X-ray is a great way of navigating, because we're able to use it to find the spot. Well, no, wait. The spot on the bone of the spine where the nerve is supposed to be. So, Sean, see where the tip of that probe is, right where the arrow is? Oh, you're moving it. You keep pulling it and you're moving it. Don't pull it. Sean? All right, you guys see where the tip of that probe is?
Yes, we do.
That's exactly where the pain nerve is. Now, part of the problem is his muscles contract every time I turn on the probe. And they're literally moving the tip of the probe from where I want it to be. So a little bit too lateral. Shot. Okay, that's the absolute perfect spot right there. So I'm going to make sure I'm anchored on the bone, which I am, and I'm turning it on. And again, he's contracting. His muscles are so tight, contracting, that it's pushing my probe off of where it's supposed to be. You see that? Is there anything we can do? No? I mean, in the end, if we can't do anything, we're just going to keep hitting at it until we get it. And I feel pretty good about it. I feel pretty good. So, like, you mean general intratracheal anesthesia? Nah. Is there any kind of local muscle relaxer you can give? Well, what I'm asking is, can you actually inject a muscle relaxer into a wound?
No, because they'll get systemic absorption and then they'll lose their area.
So it won't just stay where you want it? Huh? Well, there may be an opportunity, right? I mean, are muscle relaxers more fat soluble or water soluble? So well, I can feel the hardware. All right. Shot. So I need to be a little bit lower, right around there. Shot. That looks pretty damn good, huh, Luis?
Oh, yeah.
But I'm not on the bone. That's the problem. There. The fascia was holding me up. There. Now I feel bone. Let's just see where it is. Hold on. Shot. Yeah. So we're close. We're a little lower than we need to be, but let's see. That should be. And I feel the scar tissue from his screws and rods. By the way, I did not do his screws and rods. That's really good right there. I feel scar tissue here. So this is going to be harder to do because of the scar tissue from his prior fusion. I didn't do his fusion. His fusion was done by another doctor. Had he come to me, we would not have done a fusion shot. We would have done the laser surgery, and he could avoid all this problems from the fusion that he had. But I'm feeling the scar tissue. Shot. Yeah, that's the perfect spot. So we're in the right spot. I'm just need it burned through the scar tissue. And I'm using the plasma to do that. By the way, people think when we talk about a plasma rhizotomy, we're talking about the kind of plasma they're used to dealing with a blood donation. But we don't use that kind of plasma. We use, basically it's a energized vapor, and it's electrons. It's a cloud of electrons. That are very highly energized. And this device that we use, the Duke plasma rhizotomy generator, basically creates those high energy electrons. And those high energy electrons are what do the destruction. They destroy the medial branch of the dorsal ramus. All right, any questions from our audience?
Yes, we have a question from Trust on YouTube.
Hello, Trust.
They ask, are leg cramps, toes separate and curl up and cramp? Are leg cramps, toes separating and curl up and cramps are symptoms of a herniated disc?
So, let me understand it. Shot? She's asking if leg cramps and toes curling up are symptoms of a herniated disc. Is that correct?
Correct.
They can be. Yeah, they can be. Absolutely. They're more or less symptoms of what we call spinal stenosis. And spinal stenosis can be caused by a herniated disc. Shot? All right, so I'm too lateral there. I'm going to come over to your side because I'm having to reach over the patient a little bit. So I'm going to switch sides with Luis and see if I can't get this a little better from this side. Shot. It's looking better. There. And that should be it right there. Let's just see. Shot. Nope, too lateral once again. I need you to be a little bit more north with your fluoro. Shot? No. Shot. You can't move the fluoro. Shot? Shot? So I'm trying to get this needle in exactly the right spot. And shot. That's really good. Right there, we're just at the top of the TP. You can see on the x-ray. I lost it. Shot. I think I'm below it, yeah. The transverse process can be really tricky to get to because unfortunately they're shaped in a way that makes it hard to get on them and stay on them. Shot. There. That's probably as good as I'm gonna get it. Right there. Go ahead. So I made my incision, and this procedure, unlike a radio frequency ablation, which does not require an incision, this procedure does require incisions. We have to make a 3 millimeter incision.
This is the first level on this side, right?
Correct. Shot. So I'm on the transverse process, but I'm a little too lateral. Shot. That's better, medial-wise. And by the way, in case you're wondering, thoracic facet pain is the second most common cause of pain in the thoracic spine. The first being, that feels like rib. Shot? Yeah, it's too lateral. The first is the disc. Yeah, the disc is the number one reason people get thoracic pain. But his pain is quite characteristic for thoracic. Shot? You can see I'm right over the transverse process, right there. And it's just so hard to get it exactly where it's supposed to be. For several reasons. Number one, the anatomy of that area is difficult, the bony anatomy, because the bone is not flat like we want it to be. Shot? It feels like we're a little too high. Yeah, there it is. Shot. It's in the right spot. So I'm happy about that. Let's just hope we get it. That's one. Do not come on yet. Hold on. And let's see, 1, 2, 3. Ah, okay, fine. Shot. So you can see the perfect position for the next one. Shot. That's right there. Good. We got lucky. That one's a little easier for us. Patient seems to be comfortable. You have to have a real three-dimensionality in your mind of the anatomy to be able to do this. And surgeons generally are able to do that. But you use the X-ray, which is only two-dimensional, to help you understand where you are. But see where the tip is right there? That is literally the perfect spot. And let's just hope that this works. Okay, that's that one. 2 down. Huh? Yeah, no, it's perfect. Got two, just a few more to go. Let me see what we got there. Yeah? Okay. Shot. All right, so it's not bad in terms of an entry point. It could be a little bit lower. Let's see where that is. Shot. Too lateral. Shot. Any questions, Sean?
Yes, we have two questions. This first one comes from JMC on YouTube.
Sure.
They asked, I need to have a
Shot?
C3 through 5 ACDF, but the surgeon only wants to use a plate that helped invent. This sounds sketchy to me. Should it be? And he says he's a fast surgeon.
Well, first of all, you should not have an ACDF at all. Fusion is bad. Fusion is making surgeons richer, and you, the patients, suffer as a result of bad outcomes from the surgery. What you want to do is look into a procedure called the Duke laser disc repair. And it is a non-fusion technology. And that's what I would recommend. Shot? Shot? And as far as the surgeon using his own plate, yeah, of course it's sketchy. I wouldn't trust that. Now, that said, I use my own procedure that I developed, but there's no fusion involved. And I would, no. Yeah, here, let me have it. And I would, again, I would stay away from fusion. I don't know about the plate. Maybe it is a good plate, maybe it's not. But it could be that your surgeon is going to use the very best plate there is. I don't know. But the point I'm trying to say is avoid fusion altogether. It's unnecessary. Shot. And there's lots of complications that come about because of fusion. Shot. I think that's going to be the shot. This is a really weird TP. Shot. Shot. Not happy with that. Just a small movement of this takes you so far off, you know. Shot. Shot. That's not bad in terms of position. Shot. Shot. That feels like the best right there. That's the best. Go ahead. Do I need to make another cut? Yeah? Mm-hmm. Avoid fusion, my friend. Avoid fusion. I used to be a fusion doctor. I've done 1,000 ACDFs in my career. 1,000. Think about that. We maybe need another one of these. Well, I think we're okay for now. Any more loss of insulation and we will, okay? Is he moving or is that just you? Hold on. Shot? Yeah, don't open it, just bring it, just in case we need it. Shot. So, you're not going to hear me agree to do fusion on anybody anymore, folks. I don't believe in it. I think it's unnecessary and it's dangerous, fusions. I don't recommend it. I've done 1,000 lumbar and 1,000 cervical, but now that I've been doing the endoscopic procedures and I've seen the results are much better than fusion, and I've seen the patients, recover in 1 hour and go home. And whereas with fusions, they're taking narcotics for weeks. They have trouble swallowing. They can't swallow liquids or solids. They're literally incapacitated. People have hoarseness that's many times permanent after cervical fusion. You know. The Duke laser disc repair is less expensive. You know, if your insurance covers it, it's going to be a lot less expensive, but, you know, question is, will the insurance cover it? We don't know that until after we bill them, see if they pay, you know, a lot of times, unfortunately. Yeah, I'll take the new tip. Open it.
Yep.
Keep your fingers away, yeah? Thank you. You're going to have to shave it. Where's the knife? Yeah. 3. How do you do this anyway? Why don't you do that? You do it. I'll hold this. Just take your time. Get some light here so you can see. All right. So I've got one more rib and then 2 below. This is a good time for questions. We had one about ACDF, which I've said I don't recommend fusion at all.
We do have a question. This comes from Trust on YouTube.
Mm-hmm.
They ask, is there a certain diet that can help improve herniated discs?
Great question, Trust. There is no real diet that helps improve. A herniated disc is a structural problem that causes inflammation. The only way to get rid of the inflammation there is going to be to repair the disc with the Duke laser disc repair. The reason why we do the Duke laser disc repair is because it is the very best treatment in the world for a herniated disc. If there was a better treatment, I'd be doing it. But the problem is there is no better treatment. And the Duke laser disc repair literally is the best, and it's the most effective treatment. So you can do things like diet, exercise, change your clothes. You can change the state that you live in. You can go live with the Eskimos or polar bears. It doesn't matter what you do, that pain is still going to be there. Now, an anti-inflammatory diet, it would be recommendable. I would advise that because with an anti-inflammatory diet, you can reduce the inflammation, but you're not going to get rid of the symptoms of a herniated disc without treating it with the Duke laser disc repair. So yeah, we get a lot of people, they want to not have to have surgery, and I don't blame them. But in the end, surgery is necessary for certain things. It's unavoidable. And if you do the surgery, you'll have the best results. If you don't do the surgery, you're just going to end up being in pain. And you can try all kinds of things, but they just don't work. Trust me, if there was something other than surgery that worked for herniated disc, we'd be doing it. I'd be retired and enjoying my life, traveling, knowing that I've achieved great things and I've pretty much done, and there's not much else that I can do because, hey, there's dietary things that fix herniated disc problems. But the problem is there's not. That's the thing. Shot? So he's doing real well. Shot?
I'm wondering if there's a pencil chopper that I can sterilize.
Huh? I see, yeah.
You know, I was like,
Yeah. I know what you're saying. All right. And this should be the last 2 we're doing, right, Luis? Yeah.
yes, sir.
Yeah. All right. So let's see what we've got here. some weird transverse process there. See that? Oh. Yeah. Actually, we got 2 more after this, so. Shot? 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 Any other questions?
Yes, we have a comment and a question. This comment comes from, excuse me, from JMC on YouTube, following about his ACDF. They said, the doctor said the plate is extra thin, so it won't cause swallowing problems.
Of course it will cause swallowing problems. It's not the thickness of the plate that causes swallowing problems. That's a lie. That's how they sell you. It's the fact that it's all the scar tissue from the surgery, from putting a plate in. That's what causes all the swallowing problems. Right? Manipulation of the esophagus and scarring. I can't see the transverse process very well there. I think there's a rib coming off there. Can you change the angle, please, so we can see the TP better? Try that, Sean. Do you see it, Luis? I don't see it. Let's try, try the other way. Shot. That's a little better, actually. It's definitely better. Yeah, definitely better. What? Shot? That's it. I'm on it. That's why I was on it, but it couldn't tell. So, yeah. Listen, you're going to get bamboozled by your surgeon. That's all I can say. That's what they do. They convince you that their fusion is better. What would be better for you is no plate at all. You don't need a plate. The only reason to put a plate is so they can make more money on you. The only reason to do a fusion is so they can make more money on you. So fusions and plates do one thing: make the surgeon wealthier, make the companies that sell the plates, sell the cages, sell the bone graft, that makes them wealthier. You don't need it. You need it as much as you need a crowbar in your lungs. And in case you didn't know, you don't need a crowbar in your lungs. Shot? But I'm sure somebody could convince you do. If you ask the wrong person, they'll tell you you need it, but you don't. Unfortunately, I used to be one of the doctors telling patients they needed fusions because that's all I knew how to do. And it worked when I did it. I could actually get rid of their pain. Shot. So I was doing fusions left and right, 5 days a week, and I was helping people get out of pain, but at what cost to them? Of course, I did well financially from it, but the patients didn't need it. And I didn't know that at the time because I was like all these other surgeons, believing that, oh yeah, you need to do a fusion when you go in the cervical spine and you work on a disc, well, you're creating instability. And of course they are creating instability by taking your disc out to get to the herniation in the back. Okay? As the surgeon removes your disc to get to the herniation, they are creating instability. But you don't need to remove the disc to get to the herniation. Just look at the last video we just did today, before this one. We fixed a woman's cervical spine from Tennessee without even taking her disc out. We just went through the disc and fixed it endoscopically. There's a little bit of char.
We have a few more questions.
Sure.
This next one comes from Annette on Facebook.
Uh-huh.
They said, after DPR, will the muscle spasms lessen or go
Yes.
away? Is the spasms there because of the nerve pain?
That's correct. You are correct. So the DPR treats the facet pain. The facet pain is what causes the muscle spasms. So we would expect this patient's muscle spasms to abate, which means go away, when you fix either disc pain or facet pain. So that's the perfect position for the DPR right there. He's moving a little bit too much, but so the muscle spasms are secondary to facet joint pain or disc pain. Muscle spasms never happen on their own except in a whiplash injury. So if you get into a whiplash, and I actually had a whiplash a couple of times. One time I was in a car accident and a guy hit the side of my car and it whiplashed me, and my neck hurt for like a week afterwards. The muscles were just spasming because they were torn. That's what a whiplash is. It's torn muscles. And when you get muscle spasms from a whiplash injury where you tear the muscles. Okay, the other time I did it was when I went bungee jumping. Actually, it wasn't even a bungee. It was like weird. It was a harness, but you kind of go down, and then at 200 feet, it kind of swings you, snaps you and swings you. My head snapped, and I need to go further south. You did? Let me see. Yeah, last one. All right, I need you to come to me with the fluoro. So anyway, when you get a whiplash, a true whiplash, it's a muscle injury. No, I need you to rotate the head. Do you understand what we're looking for? See the screw, the top screw? I need to see the transverse process just to the side of that. Shot, you're going the wrong way, but you can do that. It's the other way. I'm going to be here all day until you start doing what you need to do. More until you see that transverse process. Shot, that's pretty good. That's too much. Go back a little bit, right there. All right, there's the TP. You guys see it? And TP is fine. Just leave it where it is. That's fine. Let's see if I can get to it from that incision that I already made. If not, I'll have to make one more incision. Shot? That's too high. I got to make one more lower. Anyway, so aside from a whiplash injury, you shouldn't have muscle spasms as the primary source of, as a primary problem ever. The real reason people get pain is they have facet joint or disc pain that causes muscle spasms. So get rid of the facet pain and disc pain, and the muscle spasms really do go away. Shot. There. That's better. Just got to get through the fascia. The fascia, I'm bouncing off the fascia right now. There we go. All right. Fascia is the hardest thing. Too low. There, I feel like I'm on the TP right there. Shot. And we are. It's perfect. Yeah. This is the last one right here. Another 30 seconds and we're done. I'm going to come and talk to you guys in the broadcast room in a moment. And I can answer your questions and even use models. So the tip of that probe is right where it's supposed to be. That's the perfect spot. That's right where that nerve runs. So I'm hoping that this fixes his problem. All right. Good job, everybody. Luis, nice job. Thanks, everyone. Good job. So what do you want to do? You want to do a staple? One in each or what?
I can do staple or dermabond.
Huh?
I can do dermabond.
Oh, I don't think Dermabond's going to hold, do you? Whatever you want to try. Yeah?
I mean, I can
You know, pick. All right, type up your questions for me and I'll answer them for you. Good job, everyone. Nice job. Yeah, no, that was good. And the deeper, the less muscle spasms I got during the burning. Oh, he's very muscular. EBL, I'm going to call 2 mil. This was a DPR, bilateral, T9 through L2. Whoo, he is snoring. He is one sleepy, happy sleeping man. I'm happy for him. So we've just killed the pain nerves to his facet joints, which were causing his pain. On both sides, from T9 down to L2. So we had to do an extra facet joint above than we planned, but that's because this pain was there, so I wanted to make sure we covered it all. All right, type up your questions. I'll come answer them for you.
Good morning, I'm Dr. Duke Majan at the Duke Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Duke laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7 mm quarter-inch incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Duke laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things. And he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor.
All right, thank you, Henry, for sharing that nice testimonial. And I'll start this post-operative dialogue and talk about what it is that the Duke plasma rhizotomy actually does. So for that, I'm going to try to grab a pen and a visual aid. One of our patients who didn't make it. Just kidding. It's a plastic model. And you can see in the back of the spine, this being the front, this being the back, that there are little joints called facet joints. And these are like your fingers or your knees or hips. And, you know, trauma to those joints causes an injury that you have to live with the rest of your life, and that eventually becomes painful in most patients. That's why there's so many people with back pain. So people with back pain either have hurt their disc or they've hurt their facet joint, or both. And in this case, this patient's facet joints were the cause of his pain. So if you look at a typical radiofrequency ablation, you can see the little red dot there, right?
Yeah, we can see it.
Well, that little red dot is the burn radius of a radiofrequency probe. That's why if the nerve is just a little bit to the side of that dot, you're not going to burn it. That's why people who get an RFA, they keep coming back because it doesn't work, because they're not burning the nerve properly. But with the Duke plasma rhizotomy, you can see the red patch right there, those two red patches. That's the burn area for the Duke plasma rhizotomy. That's why we're able to kill the pain nerve effectively, permanently, which is why the procedure works so well. So in theory, the Duke plasma rhizotomy is a much better version than a radiofrequency ablation. However, technically doing the job, me, the surgeon doing the job, or Dr. Patel doing the job, you know, if there's a failure, then it's a failure of us, surgeons, where we didn't do it right, you know. But theoretically it works. And we've done it now for a year, and we've had virtually 100% pain relief for each patient in the facet joints where we treat it. And the pain has never come back. So imagine a permanent RFA that works every time, that gets rid of facet joint pain permanently, so you never have to come back and do it again. Now, you may get excited about that, and I get excited about that, because to me, a permanent fix to someone's pain is my ideal goal. You know, fix the pain permanently with the least invasive treatment. But unfortunately, in the real spine world, a lot of doctors that do pain management, they don't want the patient's pain gone permanently. They want the patients to keep coming back every 6 months and get another RFA and another RFA and another RFA, and maybe some epidurals, maybe an SI, maybe a piriformis, a trigger point, a spinal cord stimulator. So the problem is we have this conflict in spine care in the United States. And every single person that treats spine problems, whether it's a physical therapist, a chiropractor, a pain management doctor, a surgeon, it doesn't matter. They all want you coming back for more treatment. And you, the patient, become a money mill. You just circle and circle, going around making money for everybody. And they have brainwashed the public to believe that back and neck pain are permanent. They're not fixable. They're only manageable with pain management and pills and marijuana and whatever other nonsense treatments they're trying to promote. In the end, there is a permanent fix for virtually all back pain. I won't say 100%, but I'll say 99% of chronic degenerative back pain. Cure. One treatment, done. The rest of your life. And that's what Duke Spine Institute does. We do it. No one else does it. We do it because we don't want you coming back. We want to fix you. We want you out of here. Go live your life normal without back and neck pain. That's our goal. We want to be done with you as a patient because that's the right thing to do. That's why we go into medicine, to fix people's problems, not temporary, make it better so they keep coming back and you keep making money off them. So we have perhaps 1 million people treating back and neck pain in the United States. And of those 1 million, there's literally one place, Duke Spine Institute, where you can go to actually get fixed. And I go on social media telling people this and they think I'm crazy or, trying to promote something that doesn't work. All they have to do is look at our testimonials and see the patients we've treated and hear their stories. And you will see that we're able to cure their pain permanently. Okay? So for this particular patient, he has like literally T910, T1011, T11-12, T12-1, L1-2 facets that are hurting him badly. And it's so bad he can't even get out of bed and live a normal life. It's not even about, hey, he wants to play football or soccer. It's just getting out of bed and dealing with the pain every day. It's so bad that it drives him to a couch, drives him to a bed. He has no quality of life. So he wants his facet joint pain gone, and he wants it gone permanently. And that's why we did what we did today. So I went in and I used the x-ray machine to find the spot where the transverse process meets the superior facet in the thoracic spine, and I ended up burning the nerves, the pain nerves at each of those spots. And if you look here at this model, this is a different model, but you can see the shape of this area right here. There's something called the mammillary process. And anyway, getting in here with that probe is difficult because it wants to slide down, it wants to slide up, it wants to go lateral. You've got to hit that exact area and you got to paint it with the probe if you're a doctor and you want to cure your patient's facet joint pain. So you got to paint it. Now the probe I use is a surgeon's probe. It's not something used by pain management doctors. So they use a different probe that doesn't work. That's why going to them for a medial branch block RFA is not going to work. It's going to give you temporary relief. That's why we're trying to raise awareness about the Duke plasmarhizotomy as a more permanent treatment. All right, let's take our questions.
First question comes from Trust on YouTube.
Hi, Trust.
Asking.
I trust you're doing well.
He's got actually 2 questions. 3, actually. The first one being, why is there no blood loss with the DLDR?
Why is there no blood loss with the DLDR? Several reasons. Number 1, tiny incision, 7 millimeters or 4 millimeters in the neck. Number 2, because I use a needle to go in first, that needle is like literally half a mil, or like maybe 1 millimeter wide, half a millimeter to a millimeter. So the tip of it is pointed, and rather than, the chance of that little point hitting a blood vessel is so small, it's almost like 1% out of 100. So there's a 99% you're going to go down without hitting a blood vessel to the disc, and then everything from there is spreading. Remember we talked about spreading. So once you create the safe path with no blood vessels being punctured, everything else after, the dilators, they spread the tissues apart. So you're not gonna spread and cut a blood vessel. That's why there's no bleeding. So small incision, no trauma internally to your body, and a very precise path with a very low chance of getting into a blood vessel and damaging it. That's why. It's bloodless surgery. Now, could I make the surgery full of blood and look like Friday the 13th, part 16? Yes, I can. If I'm not careful, I will. I mean, after all, for example, in the neck, the earlier surgery we did today, if I hit the carotid artery and I dilate that thing and blow it open, it's going to look like a red fountain squirting around the operating room. The patient will exsanguinate. It will be bloody. So, point I'm trying to make is, if you're off by a few millimeters and you get into a blood vessel that you shouldn't be, it will be very bloody very quick. But that's the way it is for every surgery. You know, surgeons choose surgical corridors. We call it a corridor, the path in between the walls, which are other tissues you don't want to disrupt. Our surgical corridors are as narrow as possible. That's why minimally invasive surgery is so good for the patient, because there's no bleeding, because you're going between blood vessels. And that's what we do with the Duke Laser Disc Repair.
Next question comes from Trust, once more on YouTube, asking, how do you know if you have carpal tunnel or cervical herniated disc?
So Trust, the way you figure out if you have carpal tunnel is a nerve test. It's called an EMG nerve conduction study. You must get it done. That's how you figure it out. How do you know you have a herniated disc? You get an MRI. How do you know the herniated disc? Pinching a nerve in your neck is the cause of your symptoms? Well, you need a good doctor. It's that simple. But basically what I do is number one, I ask the patient about their symptoms. People with carpal tunnel, they have numbness and tingling in these three fingers, and it's worse at night when they're sleeping. They wake up and shake their hand. People with a pinched nerve in their neck causing symptoms, they actually have neck pain, or they have pain from their neck down their arm. So there's something here going down. All right, now people could have both, and you have to fix both. But the nerve test is very important.
Next question comes from Michael Flores on YouTube. They ask, what would the lead time be after doing an MRI review? I'm currently suffering a C6, C7 herniation pressing on the nerve.
So the MRI reviews we do are free. This is the year 2023. We're offering them free. We get a lot of interest. We get a lot of submissions. We do a lot of MRI reviews for free. The idea here, folks, is that I want to give back to the community, give back to the world. I want people who are suffering, wherever they are in the world, to be able to get answers. We've all been patients. We've all had medical problems. We go to the doctor for answers. And sometimes we go to the doctor for treatment, but a lot of times we go to the doctor for answers. So giving somebody answers over the internet with Zoom, for me, is relatively easy to do. So I basically donate my time to these MRI reviews. I don't get paid. It's all free. It's literally 2 days a week usually, or I'm working for free. And of course, I've got an overhead to pay. I've got 70 employees. Some of them are very highly paid, and some of them, like Henry, volunteer their time. But in all honesty, we have a huge overhead, and that's where our costs are. But for me, I enjoy helping people get the answers they need, and it gives me a sense of duty and fulfillment, okay, and purpose. So once we do the MRI review, then the choice to get treatment is up to the individual. And usually if you're motivated and you tell us, I want this done next week, we can get you in next week. You're just going to have to fly here to Florida or drive and come to the Duke Spine Institute here in Melbourne, Florida. So it's really more up to you, the patient, in terms of how motivated you are to get it done quickly. But generally, if you want it done this week, we can do it this week. If you want it done tomorrow, you fly here tonight, we'll do it tomorrow. As long as you have medical clearance, which our anesthesiologist can do using an EKG and some blood work. We have our own labs here, we can draw your blood. But if you're watching this today and you have the ability to be here tomorrow and get this done, we'll do it tomorrow. That's my commitment to everybody. We don't want you suffering and waiting for weeks and months to get fixed. We want to fix you today. We want to fix you yesterday. But that's not possible to go back in time just yet. So the soonest we could do would be tomorrow.
Next question comes from Trust once more on YouTube, asking, do you know of any grants or foundations that may help someone financially for surgery that has been denied insurance?
Do I know of any grants or foundations that help people get their surgeries paid for? I don't. However, I know some people will use GoFundMe to try to get money from family and friends and other people. It's a shame because I look at this Bill Gates trust, this Bill Gates Foundation, right? And it's got billions of dollars in it. And, people like Warren Buffett donate to it for what? Honestly, what have they done? Nothing. It's a scam. You want to know what a scam is? That's a scam are these billionaires with foundations that don't help people. If they want to help people, what they should do is set up a foundation to help pay for things like Duke laser disc repair for people that can't afford it and don't have insurance coverage. That would be something that would go down in the history books as being very beneficial. But no, they do their little scammy things on the side. Like Warren Buffett gives Bill Gates money to his foundation, and Bill Gates gives Warren Buffett something back. And in the end, Warren Buffett goes from being a $200 billion person to a $210 billion person. And frankly, it makes me sick to hear about it, sick to see it. We idolize these creeps. They are creeps. They're rich. They're beyond rich. Look, there's nothing wrong with being rich, okay? I want to be rich. But there is something wrong with being super rich and not helping other people with your money. In my opinion, that's my personal opinion. Maybe I'm a commie at heart. But in the end, I think the super rich should be giving their money back in goodwill to help people that are suffering. The key word is suffering. No human being on earth should suffer. Okay, it doesn't matter what you're suffering with. You could be suffering with a medical problem. You could be suffering with poverty, with starvation, with famine, with dehydration, and nobody should be suffering. Not with the amount of wealth and technology we have today. No human being should suffer, period. Maybe people shouldn't have a Mercedes. I don't care about that. They shouldn't. But they should have access to care, whatever it be, food, water, shelter from the cold or heat, so that they're not suffering. And it's a shame that we have these billionaires like Bill Gates and Elon Musk and Warren Buffett that are so fucking greedy that they can't put their money to help the people that are suffering. So yeah, it bothers me, in case you didn't notice. Give me 1 second. It's one of my attorneys. Mitch. Oh my gosh, that's great news. Sorry.
Next question comes...
Well, I just got to say that was one of my lawyers, and I've got a lot. And he gave me good news, which, most lawyers don't do that, right? They give you bad news like, oh, your bill's going to be $5,000. But I actually got some good news, so thank you.
All good. Next question comes from Kelly, once more, first time on YouTube. And she said, have cervical stenosis, C1 through C7 sitting on each other, narrowing of the nerve. I had my MRI, CDS ready to send, also back fusion 3 years ago. My back is locking up. Can you help?
Kelly, yes, we can help. She's on YouTube?
Yep.
Kelly on YouTube. Well, thank you, first of all, for watching. Thanks for posting a comment, and welcome to our broadcast, live broadcast. Kelly, cervical spine is the problem. And by the way, just as a point for those of you, these models, they're not real people's spines, obviously, but they are actual, relatively this right size of these spines. And I want you to notice something. The cervical spine, which is of course in the neck, look at the size difference between the bones, okay? Huge difference. Why? Because you have a lot more of weight of your body on these bones in your lower back, down lower, because you got the shoulders, you got the chest, you got all the organs, your lungs, your heart, all those blood vessels, all that blood in the blood vessels. That's heavy, right? And all of it's just attached to your spine, believe it or not. And so the amount of weight going through the lumbar is much greater than the weight going through the cervical. And look at that beautiful design right there. Of course, you got a thoracic spine in between, but look at the size difference there. Huge, huge difference. Discs are bigger in the lower back and the bones are bigger. So anyway, for your cervical spine, she's got narrowing of the holes where the nerves come out at multiple levels. She said C1 to C7. She has spinal stenosis, which means narrowing. Can we help you? Absolutely, we can help you at Duke Spine. I just need to know what's wrong, and that's why we do the MRI reviews. Because during the MRI reviews, I'm going to actually have you, the patient, put your finger where you're having pain, and I'm going to be able to see it, and I'm going to be able to interact with you and ask you questions like a doctor does to a patient. And I'll do a history, I'll do a physical, it'll be very brief, it'll be very focused on that part of your spine. And at the same time, I've got your MRI, I can look at it and figure out what's causing your symptoms. I could take the average human being with neck or back problem, and I could literally figure out the cause of their symptoms and how to fix it within 2 minutes or less. 2 minutes or less with my MRI review system. 2 minutes or less. And then the rest of the time I can explain what I recommend and then answer your questions. And that's typically what we do. So if you do the MRI review at Duke Spine, we start by me asking you questions, me reviewing your MRI with you to figure out what's wrong, and then recommending the treatment, describing it, and then at the end we answer your questions. And usually by the time I'm done with most patients, they don't have any questions because I explain things as I go along and I show them on the MRI what's wrong. So the MRI review is free for you guys. And I just donate my time for it, and I love doing it because I love helping people figure out what's wrong. And 9 out of 10 people don't even come here for treatment for whatever reason. That's too far for them or whatever. They don't believe me, but that's okay. It doesn't bother my ego one bit. I've come to accept the fact that people just will believe whatever they want to believe. And in the end, for every person I can help and get them out of pain, that's all that matters to me, is that I can help people. So the MRI reviews are for you and not for me, and we enjoy doing them. Eventually I'll create an AI platform that will be able to diagnose the problems and explain the treatment so that I won't actually be doing it face-to-face with you 5 years from now, right, Henry?
Yeah.
You're going to see a virtual Dr. Duke, what's called an autonomous human Dr. Duke, explaining it to you. And we're already working on that at Duke Spine.
Next question comes from, I think this is last but not least, comes from Chris B on YouTube saying, is Dr. Patel's practice in the Atlanta area? I was told I need a spinal fusion. I didn't want it, so I just looked at the pain.
Yeah. So, Chris?
Chris.
Dr. Patel is my partner. He works for Duke Spine with me. Dr. Patel is here in Melbourne, Florida, only here. But I will tell you this, Dr. Patel is the most common name for doctors in the United States. There are many, many Dr. Patels, like literally thousands of them all over. So the Dr. Patel in Atlanta that you may know is different. I would not get a fusion. I would get the Duke laser disc repair. Fusion is barbaric and completely unnecessary. The Duke laser disc repair is endoscopic, takes an hour to do, there's no blood loss, no scarring, no pain, and it's far better than a fusion because it gets rid of your pain. Fusion, 50-50 chance of getting rid of the pain.
This is not, there's no question, this is just last comment, comes from Kelly saying, I have so much tissue damage from my L5 fusion, titanium at the L5 disc and screw rods, narrowing only at the C6, C7, but C2, 3, and 4 are sitting on each other. I'm a freaking mess. Sick of the pain. I love what you do.
Thank you very much, and I empathize with you. We can get rid of your pain. There's no doubt in my mind. I just need to know where it's coming from. And I've told people this before. in your neck alone, you have 25 causes of neck pain. And in your lower back, you have 30 causes of back pain. And when I say 30 causes, I don't mean you in particular have 30 causes, but there are 35 potential causes of chronic back pain. And it is my job to figure out what are your causes. And everybody's different, but that said, the most common causes are the same across people, right? It's all about probabilities, right? So if you're in Sweden, let's say you go to Sweden tomorrow, you land. What's the probability you're going to walk into somebody who has blue eyes, right? Very high, because there's a lot of people in Sweden with blue eyes. What's the probability you're going to walk into somebody with brown eyes? Much lower, because Sweden mostly is blue-eyed people. It just is. All right, I'm making a generalization, but what I'm trying to point out is that probabilities are part of science, okay? And what's the probability the sun will come up tomorrow? Very high, right? Almost 100%, but not 100%, but very close. What's the probability of having a solar eclipse tomorrow? Very low. So probabilities are based on science and fact. And when it comes to what causes back and neck pain, there are 25 causes of neck pain, but the C5-6 disc is the most common cause by far of all other causes. So the second most common is C6-7, C4-5, then the facets, and so on. And I have that list of probabilities in my head. And when I'm looking at a patient, I'm asking questions and I'm examining them and I'm looking at their MRI and I'm correlating the MRI with a physical exam with the history, and as an expert I'm able to pinpoint the source of the pain. But it's something that takes a lot of experience, which I have, fortunately, and I'm able to do virtually on Zoom. So I look forward to figuring out what's wrong with you. I will figure out what's wrong with you, I guarantee it. And then whether or not you want to get fixed is up to you.
And then the last question comes from Chris B on YouTube asking, do you take M better?
All right, Chris B is asking, do I take M better? Chris, I do the initial consult for free. It depends on what you need done afterwards. M better, I assume, is insurance. The problem is we don't know what M better will cover. We don't know what M better will cover until after we treat you. I know that sounds crazy, but that's how insurance companies are. They want the perception by people and doctors and hospitals that they will pay for everything you need. But in reality, if you look at your contract with M better, it's 130 pages long. It's called your summary plan document or your condition of coverage. Ask for it from your company, from M better. Ask for it. You will see a 140-page contract. The question I have for you is this: if M better covers everything, why do they need a 140-page contract with you about what they cover, right? Yeah, okay, it's obvious. They don't cover everything. And so what do they cover? We have no freaking idea. But we will fight them to get them to pay for your surgery, but that doesn't mean they're going to pay for it. These insurance companies have lawyers that write the contract so that they can slip out of it. Slip out of it. You know, look at any insurance. My house, for example, I had a roof leak and I had some mold, and they got out of paying for it. I had to pay for it myself. I had to spend like 50 grand to fix my house. All right, this was years ago. And so the point is that insurance companies write their policies with lawyers that are the best lawyers in town, and they do it so they don't have to pay for your stuff. All right, so when you ask me, will M better cover it? I have no freaking idea. They should cover it. We'll fight them, but in the end, they may not. And you can't believe what they say up front to you on the phone, because it always comes back to that contract. And when you read the contract, 130 pages, you're going to sit there and go, I have no idea if they're going to cover the surgery. And that's how we are too. So these insurance companies get away with murder, and they control our government and they control business. And I'm just one doctor who's trying to fix people. That's it. So I'm still trying to help you guys deal with the insurance companies, but I'm not a magician. So what most people do is they pay a deposit for their surgery. We bill their insurance afterwards. If the insurance doesn't pay, we appeal the decision, and then we sue them and try to get them to pay. So imagine with M-Better, we'd have to do the same. What matters in the end is that you take care of yourself and you get the medical care you need. That's what's most important.
Lastly, this is from Kelly, and she says, I'm going to mail my CDs of MRI and CT scan this week. Need address and phone number. I'm willing to fly to Florida. Do you accept ILWU insurance, PPO, Blue Cross Blue Shield?
Kelly, this is what you need to do. Go to mri.dukespine.com and fill out the form. Just mailing your MRI here, we get a lot of people who do that. It is a mistake. We don't know whose it is. We can't dig around. We can't find you. We're not like people finders. What we need you to do, and we need everybody to do, is go to our website. There's a page called Free MRI Review. It's at www.dukespine.com. Henry will put it in right now. And you click on that. You put in your name, address, phone number, all that stuff. And then it's going to give you an option. Upload your images now through a portal on the website. Send us your portal information from your MRI center, or mail in your CDs. You just pick whichever option, and then you go through it that way. Okay? Don't just send your stuff to us, because we won't know what to do with it. We'll schedule a Zoom meeting and we'll review your MRI, and then I have a team of schedulers who will meet with you afterwards to decide how much your insurance will cover, or if anything, what you have to pay out of pocket. We do the same thing for everybody. That's how we do it.
Another comment from Trust on YouTube saying, please let people know you take out of state workers' comp.
Yeah, we do take out of state workers' comp, Trust, and it just requires that my work comp team talk to your work comp adjuster in your state, and that the adjuster agrees to pay for you to come here and get the surgery. So we get all that in writing ahead of time, and we sign a contract with them. You know, unfortunately, a lot of these work comp carriers, they screw us over. Even though they sign a contract, they don't pay, and then we have to go find a lawyer and sue them, and it gets very expensive. So in the end, insurance companies generally just don't want to pay for your care. But if you can get your work comp adjuster to send you here and pay for it, then we will take it.
And that is it for questions.
All right, I hope you enjoyed the surgery, and the surgery went very well. We're going to be back again in 30 minutes with one more surgery for today. And that patient comes to us from Texas.
Yes.
Our last patient is from Texas, and she's had microdiscectomy in the past. It didn't work. She's got back pain, leg pain. We're going to go in and fix 2 discs on her back. And she has a piriformis syndrome.